Hello, my name is Kelly Tebow, and I'm with the New Jersey Center for Tourette Syndrome and Associated Disorders. I will be your organizer for this evening and would like to welcome you to our webinar on attention disorders and Tourette syndrome, a pharmacological approach. Thank you all for joining us. All participants are muted, so if you have a question, please type it in the bottom of your question box and click send. You may post a question during the webinar, but Dr. Bennett will be answering questions at the end of the presentation. We will get to as many questions as time allows. In addition, tonight's presenter is available to take your questions on the Wednesday webinar discussion board. This discussion board will be monitored for the next 7 days. Feel free to look and post questions as often as you like. Answers will be archived for future reference. If you missed part of the presentation or would like to hear it again, an archived version will be posted to the website shortly. When you exit the webinar, there will be a brief exit survey that we would like you to fill out. New Jersey Center for Tourette Syndrome and Associated Disorders and its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now I'm going to turn over the introductions of our speaker to Martha Butterfield, the Program Coordinator of NJCTS. Marty?
Thank you, Kelly, and good evening, everyone. I'm very pleased to introduce Dr. Harvey Bennett to our webinar audience. Dr. Bennett graduated from the Albert Einstein College of Medicine in New York and has been the director of the Division of Child Neurology and Developmental Medicine at Gloria Children's Hospital in Morristown, New Jersey, since 2005. He is also clinical professor of pediatric neurology at Mount Sinai School of Medicine in New York. He is board certified in pediatric, child neurology, and neurodevelopmental disabilities. Dr. Bennett has a long-standing clinical interest in neurodevelopment disabilities with special interest in cerebral palsy and Tourette syndrome. Dr. Bennett, welcome.
Hi, thank you, Marty and Kelly. Am I on? I guess I am.
Yes, you are.
It's a pleasure to, how do I get rid of this screen? Hide control panel, got it. Okay, I'm a little new at this. You see, this is my first webinar. I thank the New Jersey TSA for letting me give this talk. It's a fantastic organization that my patients have benefited from. My office is always referring patients to you, and I appreciate everything the New Jersey TSA does. When we were deciding on a topic tonight, I did pick this topic because it is one of the main things that I do, and that is a pharmacological approach. But I want to have a disclaimer right at the beginning, is that just because you have Tourette syndrome or just because you have attention deficit disorders, it does not mean that you need to be on medication. And we will talk about medications tonight. I'm going to go to the next slide. The next slide's not going down.
Just use your arrow keys on your keyboard.
I'm trying.
Okay. Click on your presentation screen and then hit your keyboard.
Well, it's not going.
Okay. Move your mouse to the lower left-hand corner.
Yep.
And click the other arrow. Slide to the right.
That arrow.
That's backwards.
There we go. Okay. Sorry.
No problem.
So I will be mentioning a lot of medication tonight. I tried to use generic names throughout, but some medications are just known by their brand names, so we had to use some of them. I have no disclosures, no financial disclosures, and you wanted to make that clear at the beginning. I told Marty and Kelly that if I'm talking tonight about Tourette syndrome and I have such a varied audience that's logged in, I had to level the playing field, and I had to give a couple of slides to make sure we all know what we're talking about. And as mentioned, I am a child neurologist, and have been so for many years. And Tourette syndrome is a neurological disorder manifested by motor and phonic tics with an onset during childhood. And therefore, it has been a passion of mine for many years, as many of my patients, and some of you are logged in tonight, know. But Tourette syndrome is also one of those unique neurologic diseases that that other professionals share its interest, namely child psychiatrists. And Tourette syndrome does make the Diagnostic and Statistical Manual of Psychiatry, and this is the DSM-4 criteria, which one day, perhaps in the next year or two, there will be a DSM-5, but the criteria for Tourette syndrome will not change. And one needs motor and vocal tics present for a considerable period of time. That has to have an onset before age 18. And it has to be present for at least a year, and it has to be not due to any particular medical illness. Again, this is perhaps very mundane to everyone who has TS and knows about it, but the tics need to be stereotypic, need to be repetitive. They could be movements or sounds. There's often a feeling or sensation before the tic. And it's one of those interesting movement disorders that there can be voluntary suppression, there can be suggestibility, but clearly it is an uncontrollable movement disorder. And of course it's unique in that the tics are often worse in stress, but they also can be worse in relaxation. That might seem oxymoronic to some people, but it's definitely true, as most of you know. Motor tics are just simple motor tics are fast-darting, meaningless, usually single muscle groups, eye blinking, grimacing, jaw snapping, shoulder shrugging, whereas complex motor tics are multiple muscle groups, and there are some examples of hopping and clapping and kissing. Verbal tics are meaningless utterances that could be as simple as throat clearing or sniffing or high-pitched sounds, and complex vocal tics are usually words or phrases. So in order to understand the pharmacology of Tourette syndrome and its associated features, we have to know a little bit about the neurobiology of Tourette syndrome. And Tourette syndrome is a movement disorder, and movement disorders are considered based in the basal ganglia, the middle part of the brain. And you see the caudate, putamen, globus pallidus on your slides, on your slide there. But what's unique about Tourette syndrome, unlike, I always like to, and most neurologists divide movement disorders into hyperkinetic movement disorders and hypokinetic movement disorders. And Tourette syndrome would be a hyperkinetic movement disorder. And if you think of Parkinson's, for example, that's a hypokinetic movement disorder. And where in Parkinson's, the deficit is really in the globus pallidus, where there's a lack of dopamine production. But in Tourette syndrome, the problem is in the what we call the cortical striatal pathways, cortical striatal thalamic pathways, the feedback mechanisms between the cortex, the frontal cortex that you see there on your slide, the thinking part of your brain, and the basal ganglia. So what happens in the basal ganglia is really important for us for any motor pattern, and it makes us have our movements smoothly. But in TS, there's increased areas of excitability, and the regular inhibitory mechanisms in the basal ganglia are not in balance, and you get exaggerated activity. And this is our current understanding of Tourette syndrome, that you need to have a genetic predisposition. Sometimes the genetics is simple when you have first-order family members who are involved, and there is It's a developmental problem, and we all know that tics are much worse in childhood. They tend to get better in adults. But the problem is really dopamine, that there's a hyperinnervation or too much dopamine around in the striatum and in the limbic system. And this gives you this impaired corticostriatal thalamic loop, and you therefore get all those symptoms on the bottom of the slide. Tics, attention deficit disorder, and obsessive compulsive disorders. These are part of the hyperkinetic movement disorders, and that's why patients with Tourette syndrome very often have what we call comorbidities. They have ADHD, they have obsessive compulsive mannerisms, and they're much more anxiety and more mood disorders. Those other items, learning disabilities, sleep disorders, migraines, it's very hard to figure out if that's part and parcel of the Tourette syndrome or the hyperinnervation. I need to just give you one slide on pandas. I really don't want to talk about pandas. I know that Dr. Kurland gave a beautiful webinar a few months ago on this, and it's just that antibiotics are given by some people, and I had to mention it as part of the pharmacology of Tourette syndrome. But I think we have to know that PANDAS, which stands for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Strep, we have strict criteria for that, and there needs to be an explosive onset of a tic disorder or OCD, and there needs to be a temporal association with beta-hemolytic strep, and there often are psychiatric comorbidities. I think the most this is a very controversial area. Some people do not believe it exists at all. Some people believe it's very rare, and there's a major spectrum. Some people think the fact that genetics are part of this makes a part of Tourette makes this extremely unlikely. It really is a complex field, and I'm really not dealing with any antibiotics or immunomodulatory therapy tonight. But let's talk about medications that are used in patients with Tourette syndrome. And the problems that the main problem in Tourette syndrome is tic suppression. Some people want a magic pill that will stop their tics. We don't have one of those. I mentioned earlier on that I always prefer when my patients are not on medication, but sometimes there is a role for medication for tics. Patients are embarrassed. Patients have pain associated with their tics. It's socially unacceptable. We don't have great medications for tics, but we do put this large laundry list of medications into what we call Tier 1 and Tier 2 medications. And these medications, the Tier 1 and Tier 2 really are somewhat divided by side effects that you always, as a physician treating a problem like tics, that's a chronic problem. You really try to minimize your side effects because you're dealing with a chronic medication that somebody might be on for a long time, and having side effects affecting mental status, affecting school performance is certainly undesirable. So some of the Tier 1 medications are the alpha-adrenergic drugs. Both clonidine and guanfacine are used often because they are relatively benign drugs. Clonidine, the other name is Catapress, guanfacine is Tenex, and they are fairly effective. Their major drawback is their sedation. Clonazepam is a benzodiazepam, and Klonopin and gabapentin, Neurontin, and topiramate, and levetiracetam are three anti-seizure medications that are fairly effective in tic suppression. My favorite lately is topiramate, Topamax, that I find has almost nothing in the way of side effects if given in a low dose, and you can give it in a much lower dose than you need for seizure control. So that's one of my favorites lately. But I must say, some of these drugs on the tier 2 seem to be more effective. Pimozide, ORAP, has been used for years and not quite as long as haloperidol, Haldol, but the Pimozide and Haldol are somewhat equivalent, as well as the other ones listed there, flufenazine and the stelazine. But those are what's called the typical antipsychotic drugs, or typical major tranquilizers. But the atypicals, the risperidone, olanzapine, Abilify, Seroquel, are perhaps as effective, and you run less complications of the of long-term effects of some of the typical medications. Then we have, really tier 2 or tier 3 medications that you use in patients with who you have, you're down to patients' tics not being suppressed, and what else can you try? Aricept has been tried, Pergolide has been tried, botulinum toxin injections have been tried if you have a tic in a certain area, as well as a nicotine patch. And there are certainly patients who have tried delta-9 tetrahydrocannabinol, otherwise known as marijuana, and they say it's effective. That's not been tried in any systematic way at this point. The OCDs seem to be best treated with the SSRI group of medication, in which Prozac, fluoxetine is the granddaddy, but probably not used as much. That Zoloft, Paxil, Luvox, and Afrinil are much more commonly used for obsessive-compulsive behaviors and anxieties. So what about attention deficit disorder? We saw before that attention deficit disorders are a very common comorbidity of patients with DS, and the problem is that always in attention deficit disorder, this is another neurological event that has a neurological treatment, but that is shared by psychiatry. And how does one make the diagnosis? So there is a DSM-4 criteria, and anytime somebody has gone to a physician with attention deficit disorder, one's asked to fill out various scales to find out if they have the diagnosis, if they have the symptoms. And you need, there are a number of core features of the attention deficit disorder. One is inattention, and the other is hyperactivity, impulsivity. And you need to have 6 out of 9 to be called inattentive, and 6 out of 9 to be called hyperactive impulsive. And these are kind of somewhat self-explanatory. You fail to give close attention to details and make careless mistakes. Difficulty sustaining attention, often does not seem to listen when spoken to, often does not follow through on instructions, fails to finish schoolwork, often has difficulty organizing tasks and activity. We call that problems with executive function, often avoids or dislikes, reluctant to engage in tasks that require sustained mental effort, and often loses things, often easily distracted by extraneous stimuli, often forgetful in daily activities. The hyperactive impulsive list is probably less common. There are many people with, and we'll talk about the criteria for the diagnosis in a moment, but these are some of the hyperactive impulsive that parents check off, or individuals check off when they fill out these scales, that you fidget, getting out of your seat, runs around more, has difficulty playing or engaging in leisure activity, often on the go, often talks excessively, blurts out answers, difficulty waiting turn, or interrupts others. So to make the diagnosis, you have to have, according to DSM-4 anyway, you need to have at least 6 months of maladaptive or inconsistent with the developmental level, and that they need to, this is a start in childhood, and this impairment is present in at least 2 modalities, in both school and work, school and home, or work and home, and then you could, and there needs to be a clinically significant impairment before one would consider medical treatment. At least I do. There are 3 types of attention deficit disorder. This is the combined type, which is probably the most common. Those children who are hyperactive and impulsive and have problems paying attention. And then there are children who are the type 1, which is the inattentive type, predominantly inattentive type. They have elements of both, but they're predominantly inattentive. And then there's the predominantly hyperactive or impulsive type. So what are the common medications that we use for attention deficit disorder? And the best medications for most attention deficit disorder are these stimulants. And methylphenidate, there are so many different types of methylphenidates out there. There's the granddaddy is Ritalin and Ritalin SR, and there's Metadate, and there's Focalin and Concerta, Baytrana patch. Those are all different forms of methylphenidate. The amphetamine group is the mixed salt, the Adderall, and lately the Vyvanse, which is a very effective group of medications. And the side effect profile of patients on methylphenidates and dextroamphetamines is about the same. For predominantly hyperactive, impulsive types, we tend to like the clonidine or the atomoxetine, which is Strattera, better. Guanfacine is kind of like clonidine, and those next three medications with long names, depramine, nortriptyline, impramine, are all tricyclics, and those other antidepressants are not used that commonly. The mainstay of treatment, in summary, the mainstay of treatment of attention deficit disorder is the methylphenidates. But what about this question that, which was really when Marty and I were talking about what topics to discuss tonight, this is something that comes up all the time. I know there's at least one person out there who's listening who I met with a few hours ago, and this was her and her son's questions. Is, are my tics worse because of stimulant medication? Way back in 1977, a friend of mine wrote a first report that stimulant medication were, Dr. Pollack, associated with the potential to provoke or intensify tics, and other authors caught on that this was a problem. And but then articles started to come out, well, maybe this is not the case. I mean, there was a time when we really hardly gave stimulant medication to tics with children with tics. We felt it was contraindicated. Then more and more articles came out that that this was not the case, and that perhaps the tics exacerbations that people see are only occur at the beginning or only occur with very high doses. There was a postulate that the methylphenidate was more of a culprit than I'm sorry, that methylphenidate was less of a culprit than the amphetamines. There was a beautiful article in Neurology, the journal Neurology, in 2002 that studied 136 children with attention deficit disorder and chronic tic disorders. They all had those criteria. They were randomly assigned to 4 groups of medication, either clonidine alone, methylphenidate alone, clonidine plus methylphenidate, or placebo. And the results were striking, that there was a significant improvement of ADHD in all the treatment groups compared to placebo, and tic severity also lessened in all treatment groups compared to placebo. But there were a similar group of patients with worsening tics with all 3 medications, with methylphenidate, clonidine, and placebo. So it was a very helpful study to come to the following conclusion, that there is some evidence that stimulants, there's significant evidence that treating attention deficit disorder is important, that sometimes the non-pharmacological approach to attention deficit disorders is not sufficient. The bringing back, the refocusing, the extra help. Sometimes there are patients who need medication for their attention deficit disorder. It seems as if methylphenidate therapy does not induce somebody's tics if they weren't going to have tics. And the exacerbation of tics is really debatable. On an anecdotal basis, it's true, but it seems to be not a major clinical problem. and certainly if somebody needs medication, stimulant medication for their attention deficit disorder, it should not be given. Sometimes we try these other medications, these are alternatives, atomoxetine, clonidine, or guanfacine, which all those drugs tend to be better in the hyperactive impulsive type, do not work as well on the mostly inattentive type. So, but we sometimes try to choose that because these drugs are somewhat tic neutral, it seems. So I think, what do we do when somebody has these symptoms? What's our pharmacological approach if we do need medication? I'll put that caveat again in for the third time, that we need to identify the symptom that needs to be treatment. We need to explore the non-pharmacological approaches. And that if there is more than one symptom that needs to be treated, it's always better if you can have monotherapy. But there are times when monotherapy it just can't work. If someone's needed to have an SSRI for his OCD, and he's needed to have a medication for his attention deficit disorder, and his tics are out of hand, you might actually have a patient on 3 drugs. That's unusual. We always prefer patients on less medication, but sometimes we must use more than one drug. And if we do that, though, we should be very aware of the cumulative side effects and interactions of these drugs. And I think that if we are, we will have good success in managing our patients. So again, I thank you all for listening and logging on, and I think I did get out the information that I needed to in that half hour allotted to me, and interested to hear your questions.
Well, we have a lot of questions, so I'm going to get right to it, and we'll cover as many of them as we can. Through your whole presentation, you talked about drugs and the variety of drugs being used and the possibilities of using them. But how does a parent know when it's time to begin to consider using drugs? I mean, obviously that's in conjunction with the doctor, of course. But is there any criteria there, any rule of thumb that you follow?
Again, you need to drugs for what? You need to identify the symptom. So if you're asking the question about attention deficit disorders, again, we always try to manage, if we can, attention deficit disorders non-pharmacologically. They need to be in the right educational setting. Who needs medication for attention deficit disorder if you have a one-on-one teacher and somebody who is constantly refocusing the child? Very few, because that's basically what the medication does. But there are times when your non-pharmacological approach is not going to work in a patient with attention deficit disorder, and you will have, and if they have mostly inattentive type, you will need to go to a stimulant medication.
Okay. In this particular case, the question didn't define that specifically, so it was more general, just in considering, where to begin.
Okay, so I gave the example. Go ahead.
No, go ahead.
So I gave the example of attention deficit disorder, and and tics themselves. There are a lot of patients out there listening, probably, especially the older ones, who understand that tics don't have to be treated. That no one tics don't hurt people, and they are perhaps bothersome, perhaps annoying, perhaps socially unacceptable. But there are people who are at peace with their tics and do not want to be treated. But you do need to go on medication for your tics if your tics are getting in the way of your life. If you're in school and everyone is making fun of you and your teacher's always asking you to come out, to step out of the room, that's unacceptable.
Yeah.
If you're in pain from your neck twitch, then that's unacceptable, and then sometimes the patients need medication.
All right, so that would be the time to start then. Okay, I have a question about focus problems. In this particular instance, this girl is taking Topamax and has seen a really good decrease in her tics. Concern is with focus problems, and the mom would like to know how Topamax affects ADHD, and what medication you might suggest if Topamax, with the Topamax for ADHD.
I don't think Topamax is causing her focus problems. I don't know that 100%. I'd like to know the dose she was on, but Topamax can rarely cause, in the dosages that we use for tics, can rarely cause like a word-finding difficulty. But it generally is not sedating, and generally does not cause a focus problem. And if the Topamax has been very successful in stopping their tics, and their inattentiveness is so problematic that it needs medication, then that might be the type of child that does need 2 medications. There might be a child who needs a stimulant and Topamax.
Okay, and you wouldn't be in a position right now to even discuss what that stimulant might be. Am I correct
I think
in that?
You need
yes.
to. You need to. We go with either a methylphenidate derivative or if it was mostly inattentive type, it would depend on the if it was mostly inattentive, which is most common, you would go with a stimulant, or you'd go with a methylphenidate or dextroamphetamine. You would go with the Concerta group or the Vyvanse group as a first line.
Okay, thank you. Are there any long-term effects with Tourette? And this mom is asking about whether or not it would be worth taking the child off meds to have successful time in school.
2 separate questions, obviously,
yes.
right? So is Tourette is not a stimulant. It's a norepinephrine drug, not a serotonin dopamine drug, but but it also does not have any long-term side effects. Tourette does have problems with sedation, with abdominal pain, and I always like when my patients go on drug for attention deficit disorder meds, go on drug holidays. Not my seizure patients, obviously, but one doesn't, for a few reasons. One, just as that mother suggested, need to know what the child's like, off the medication. Need to know, does he really need it? Sometimes when somebody's been on the same medication, whether it be Strattera or Concerta for many years, you don't know how you're like. Do you still have those symptoms that when your children change? They mature. Their clinical situation changes. Their school changes, and where they're at in life changes. So just because you're on a medication doesn't mean you're on it for life. And there's because of these symptoms that we're treating, we're not dangerous. We're not talking about going off your seizure medication and presenting to an emergency room with status epilepticus. You're talking about or going off your hypertensive medication and having your blood pressure go through the ceiling. But you're talking about, so we'll try you off medication and your ADD symptoms will come back, which is kind of good to know that they're back, and that well, maybe I need to go back on this medication. I have a lot of my patients with attention deficit disorder stop their medication for the summer and reassess whether they go on in September.
Okay. I have a question about, there apparently were some findings reported about a link between histamine and Tourette. Can you provide any additional information about that?
Not really. Not familiar with that.
Okay. I have a couple of questions about this medication, and I want to spell it because I'm not exactly sure how to pronounce it. It's INTUNIV, Intuniv.
Okay.
With regard to ADHD symptoms, and would you comment on that?
Sure. Intuniv is long-acting guanfacine. It's Intuniv is the brand name, and it can be given once a day. many of the medications that we use for attention deficit disorder are very short-acting medications, and by changing the delivery system, the companies that make them have let them last longer. So Intuniv, you can replace Intuniv on those slides with guanfacine, and it's an extended release preparation. I'll just repeat what I said earlier, that this is these are good medications for predominantly hyperactive, impulsive type. They're not bad medications for tics. You might see an improvement in somebody with tics, so it's nice to go with the guanfacine clonidine group, because you can sometimes improve somebody's tics and improve somebody's hyperactivity with that monotherapy that I always said I prefer. So there's been a lot of marketing. I'm not surprised we're getting a question about that drug, because there's been a lot of marketing about that drug. It just came out last year.
All right, thank you. I have a question that has to do with seizures, and the question is that is it possible that you could have a tic that would present like a seizure, where the body shuts down and the victim is unconscious?
Okay, so those are completely two different things. I mentioned that early on, that tics are a movement disorder. They come from the basal ganglia and the cortical striatal loop pathways, but seizures come from the cerebral cortex, and they are a electrical phenomena much more than a chemical messenger problem. And is it possible to have a type of tic that looks like a seizure? The answer is yes. Most seizures, but most of the time, most clinicians can figure out the difference between, clinically, can figure out the difference between a seizure and a tic. But sometimes an EEG is extremely helpful in knowing the difference. You really can't have seizures with a normal EEG. Patients with Tourette syndrome, patients with tics, should have a normal EEG. Patients with active seizures should have an abnormal EEG.
Okay. I have a question from a mom. She has a son who's now 24, and he's been taking tetrabenzine. I'm sorry, I'm having trouble with some of these names, for a few years.
Right.
Along with Abilify and Lepraxo and Orep. And she's asking about this cocktail and what your thoughts are on it and what results you may be aware of.
All right, hold on. He's on Abilify,
Lepraxo, and Orep, as well as
Lexapro.
Lexapro, I'm sorry, yeah.
Abilify, Lexapro, and
Orep.
And Orep. So it's on 4 drugs.
Yes.
Okay, so again, the hair rises on my neck when somebody's on 2 drugs and 3 drugs, let alone 4 drugs. So Lexapro is an SSRI, Abilify is an atypical. Obviously, the Oreps is being given for his tics, as is the tetrabenzamine. So I would be concerned about sedation or the patient not being as sharp as usual. I think that's a lot of medication. Was there a particular question about that cocktail, or?
The question was really what your thoughts were on it, and if you're familiar with it, have there been any positive results or any results that you're familiar with? In this particular case, we're talking about a young adult at this point now, 24 years old, and that he's been on it combination for a while and actually seems pretty comfortable with it.
If he's doing well on it, then that's great. I think it's it's not unreasonable at all. The drugs are working for different things, it sounds like, and you know,
all right. Well, I think
again, I think the important thing is that it's if he feels comfortable on it and it's working, I don't think there's any danger in it at all.
Right, and I think that's the key to it. It seems to be working for him, and I'm sure it didn't start there overnight. It was a progressive thing that
exactly. It was probably added on over the years and built up. Yeah.
Would you discuss a little bit a recommended treatment for rage? Now, this child has TS. I don't know how old, but there are rage issues here, and would you recommend anything or suggest something for that?
Well, that's a difficult question. I had somebody like that just the other day. You know, I need help from psychiatry colleagues in this, I think this is, those rage attacks, and the young man who I saw the other day, just at the drop of a hat, was down his mother's throat, and he was so volatile. It was, I felt for this mother who, came to me for this problem. But I think he was an intelligent kid, and he himself doesn't know why he did this. And I think this would be amenable to to CBT, to cognitive behavioral therapy. I think loading him up with atypicals would probably not be in his best interest, but rather cognitive behavioral therapy would be the way to go.
Okay. Let me see. Let me just come to another one. Sorry, I have so many questions here. I lost my spot. I have a question about dietary impact on ADD, specifically high magnesium, high protein diets. And could you talk about that a little bit, and if you have any thoughts about that approach?
Diet's always a question. The omega-3 oils are popular these days. Various homeopathic or processed free food, or are discussed. Eating a healthy diet is important for anybody. There have been, unlike these medications, which have been, especially some of the tier 1 medications and the medications I mentioned for attention deficit disorder, where there have been controlled studies that that this works and that works. There's been no, what we call evidence-based medicine on any dietary manipulation. I think eating a healthy diet, nutritious diet, is helpful, but there's no one diet that can cure ADHD or tics.
Okay. Do you find any benefit to short-term use of meds to get a child through a particular bout with tics, which is just a particular rough patch? And this parent is specifically mentioning a neck-jerking kind of tic that's particularly painful. So some kind of meds for a little while just to get through this and then stop. Do you have an opinion about that?
Absolutely. No, I've done that often. Gotten children through. Listen, tics are often worse during that we mentioned earlier on in the slide about that anxiety, stressful situations can make tics worse, and sometimes there are children who need to be treated for a short period of time, or sometimes there's a particularly, as you mentioned, in the neck-wrenching type tic that it's extremely problematic for the child, or painful. That would be an indication to go on some tic suppression medication.
Okay. Have a question involving an 8-year-old who has moderate to severe Tourette and OCD. The tics are a low level, not particularly bothersome, but the OCD is consistently high level and is more of a problem. So the question is, are there long-term health effects to be aware or be concerned about for a growing child? In this particular case, the child is on an SSRI and risperidone. And those are the things that are recommended, but the mom is concerned about the long-term effects of that combination.
Excellent question. As you can see from this very good question, that and many parents out there know this, that even though one has Tourette syndrome, it's not the tic disorders that are more bothersome or most bothersome to many patients and their families. It's the comorbidities. It's either the attention deficit disorder or the obsessive compulsive disorders. And obsessive compulsive disorders can be so limiting, as far as the child going to school or just getting out in the world. If you have to, if you spend 3 hours giving a perfect homework assignment, or if you're spending an enormous amount of time checking things or unchecking things, or setting things just right, that is so debilitating. And patients need to be on, a patient does need to be on an SSRI. The good thing about SSRIs is that their side effect profile is really relatively benign. Those same group of SSRIs is used in depression, and patients are on it for years. Yes, there are some things to be concerned about in adults, such as libido and remote diabetes issues, but weight gain. But by and large, they're minimal. And if a patient's OCDs is making him non-functional, then he needs to be on an SSRI. And if the atypical of risperidone in this case is effective on tics, then the patient might need to be on their tic medication. But there might come a time when that patient does not need, that he's more at peace with his tics and that he will not need medication, and that risperidone could be decreased.
There's a number of questions that have come up about long-term effects, and there's another one along the same line. Is it reasonable to try several other medications rather than just stay on one thing for a long period of time? Would it seem that maybe you take a holiday and see where you are, and then go back and maybe return to the same medication or try something different? But is it not good to stay on one for an extended period of time?
Which symptom? ADD symptoms?
Well, let's see. This particular, doesn't say specifically. This particular instance, he said he's used clozapam, clonazine. I can't read it. It's misspelled, and I'm not sure what it is.
Well, if it's, I'll answer it.
Okay.
I'll answer it both ways. So, if the symptom here is attention deficit disorder, and I did mention that yes, it's very nice to have drug holidays. It's very nice to see what one does off of medication. It's very nice to see if one still needs medication. Sometimes it's evident in one day off of medication, particularly in the hyperactive, impulsive types. You go off medication, oh my God, does this child need this medication? But sometimes, if there's much less stress going on in the family, then the child adjusts to being off medication. And I agree that you shouldn't necessarily, stay on the same medication forever by any means. And if you're talking about tic suppression too, the problem with tic treatment is that I think I mentioned it in one of the earlier slides, that there's a natural history of tics waxing and waning. And our big problem with tic suppression medication is we don't know whether our medication's worse or whether the person's tics are just better. We don't know if the tics are worse. We don't know if the medication is wearing off or not as effective, or this is just a time when somebody's tics are worse because of their striatal cortical loop mechanism is just hyperinnervated, and things are just worse. So the same thing. If I have somebody on tic medication for a long period of time, and they're kind of their tics are not going anyplace, they're kind of just a steady state, then I'll try and get that patient off, or lower the dose.
Okay. I have a question about the Daytrana patch for ADD. And I would guess might be a teacher that's referring to this, that they have several students that using the patch. The students generally have anxiety as well as focusing issues. But the comment is that they're noticing weight loss and inability to eat during the school day. And then to that same point, there was another part of it. They still see anxiety, and we're interested in your comments about the dosage because it's being absorbed through the skin. Talk a little bit about the patch.
Okay, so the patch is a methylphenidate patch, and it comes in different strengths. I think it's 5, 10, 20, 15, and 20, and to me, there's really very little advantage to the patch. I mean, the only patients that I put on patch are those who can't take pills, and to those patients, it's certainly wonderful. Otherwise, the other advantage to the patch is that you can, a parent can just take it off when they get home, and it lasts for another hour or two, and they're still getting some benefit. The problem with patches is rashes. You try to alternate hips to prevent that, but that is certainly a problem. But basically, the patch is the same thing. It's methylphenidate, which is Concerta, Metadate, Ritalin, Focalin, and we always worry about mood in patients with patients on stimulants, and that is one of the side effects that we're concerned about. Depression and mood instability, that is a side effect of being on stimulants, and if somebody is going down that road, we often have to stop stimulants.
Okay. I have a question about taking a medication vacation from Zoloft. This question pertains to a 14-year-old, and the comment is that they understood this was dangerous for teens to take a vacation from something like Zoloft. Would you comment on that?
Sure. Okay, so Zoloft is an SSRI, and it, unlike the stimulants, which are extremely short-acting, Zoloft is something that you need to build up and need to wean down. And when you go off of it, you can go off of it safely. Again, the symptom is not. It depends what you're treating for. If you're treating it for OCDs or if you're treating for depression, there were a number of papers a few years ago about suicide in teenagers on the SSRIs, and this, I think even for a while there was a black box warning to some of these drugs, the Prozac and other SSRIs, and but I think now the tide has turned, and patients were not given the drug, but I think we have looked at that data and said that those patients who did commit suicide were depressed individuals, and and the suicide rate was not necessarily because of going off the drug or going on the drug, but rather because of their primary depression. It certainly was a scary time for people who prescribed those medications. I think if there's a reasonable indication to be on the drug, then you need on an SSRI, you need to be on it.
You need to be on it. Yeah.
I think if it's not unreasonable at a certain point to say, do I still need to be on it? And let's try and go down slowly and see if it makes a difference if you're on 100 or 50 or 25, and then maybe you can do without it.
Okay, fair enough. Question having to do with ADHD, and the comment is that this individual has heard that if someone is unresponsive to ADHD pharmaceutical treatment, then the patient does not have ADHD and was misdiagnosed. Would you care to comment on that? Would you agree with this, or are there a percentage of patients that don't, that have ADHD and just don't seem responsive to meds?
First of all, the stimulant medication, that really can't be used as a clinical trial, meaning if it works, you have ADHD, and if it doesn't work, you don't. There are some patients who just don't respond to medication. I think they meet all the criteria, and remember, part of the criteria was not having exogenous things that caused ADHD. I have this often, by the way. I am surprised there wasn't a question about this, and maybe it'll come up. So I'll just open this door. Is the children with Asperger's or PDD often look like they have attention deficit disorder, and they also have tics more commonly, and they're both difficult to treat, and you do not get as good a treatment response, even though somebody might have enough of the checkoffs and meet the diagnostic criteria for attention deficit disorder. But they're internally distracted, and their ADD is different, and it often using medication, the stimulant medication, is not effective in those patients. So to get back to this question, if you don't respond, does that mean I don't have ADHD? I don't think so. I think there are confounding factors, and it all needs to be taken into account.
Okay, thank you. I have a question from a 19-year-old who says he has OCD, TS, and ADHD, and he's currently taking Lexapro, 10X, Topamax, and Klonopin. And I think I said he was 19. And so his question is this too many at one time, or is one drug making any of these symptoms worse?
So he, 10X, Klonopin, Topamax, what was the third? Lexapro. So I think the person who's treating him probably knows what he's doing, and those are 4 different drugs and 4 different class of drugs. The Lexapro is an SSRI, the Topamax is an anti-seizure medication or for episodic events in the nervous system. The Klonopin is a benzodiazepine and somewhat of an anti-anxiety medication. And the 10X is an alpha-adrenergic drug used for blood pressure and much more effective in the hyperactive, impulsive type of attention deficit disorder. I assume the person who's giving him these drugs is using each of them for different symptoms. And
I would say that as well. Yes.
I am concerned that the 10X and the clonazepam are both sedating drugs, and I hope his dosages are reasonable, and I hope he is as sharp as he could be or should be.
Okay, fair enough. I have another question from an adult, 44 years old with TS that has gotten worse since being a teen.
What's gotten worse?
TS, sorry. With TS,
okay.
That has gotten worse since being a teen. Times can be difficult with TS, but what meds would you consider for moderate tics along with some ADHD? And again, we're talking about a 44-year-old male.
Primarily, I think, I guess I assume it's a primarily inattentive type. If it's a primarily hyperactive, impulsive type, then he might do better on a single alpha-adrenergic drug with clonidine or guanfacine. And maybe if he took a long-acting one like Intuniv, he might help his tics, and it might help his attention deficit disorder. Or Strattera might be a drug that would be good for him. It would, again, be good for his attention deficit disorder. It might help his tics. I've had an occasional patient with a surprisingly dramatic response to tics on Strattera. I never quite understood it, not necessarily in the literature, but Strattera might be a good option for that gentleman.
Okay, good. Thank you. I have another question having to do with medication vacation. And the question is, this parent is concerned about having their child on medication 7 days a week. So we're talking about, being on meds during the weekday and off on weekends. Is this, would you talk about vacations like that, or would you, think of a vacation in a longer term, like over the summer?
I have a lot of patients who take their ADD medication Monday to Friday. They just don't need it on the weekends. And these are the stimulant medications are short-acting medications. They're in your system and out of your system in 8 hours, 10 hours, maximum 12 hours. If they don't need it on the weekend, if they're not in school, or they really can just hang out on the weekend, then why give it to them? And they can restart it on Monday with impunity. So, and those same patients often don't take medication in the summer for their ADD.
All right, so a weekend time off then is not uncommon, and but how about build-up time? Because that actually is another question. Does the medication need to then build up in your system again? Is there a lag time then if you do that?
Not in stimulant medication.
Off? No? Okay.
In stimulant medication, that medication you take on Monday morning is for Monday. And the medication you took on Friday morning was for Friday. And the fact that you didn't take it Saturday or Sunday, it's very quickly metabolized.
Okay. Would that apply? Again, you're certainly the expert on meds here. How about Strattera? Is that a type of medication that needs to build up, or is that?
Strattera is a little more problematic. And Strattera requires more of a build-up. Are there patients who do it? Yeah, but it's not as, might not be as effective. Strattera is less effective, in general for inattentive type of attention deficit disorder, but it needs to be built up somewhat.
Okay, now I don't know what, specifically what those Strattera is being taken for, but it mentions that if you wanted to switch to a new medication and you're taking Strattera, was the one mentioned, so it's built up in your system for 6 months, would you need to then be off that for 6 months to have that come out of your system?
No, not at all. You can just stop it.
Okay,
again, you have to realize what's the downside of stopping it. It's not like stopping an anti-seizure medication. And even though it takes time to be effective, you can stop it with impunity.
Okay. Let me see. I think we have time for one more question here. So if any of our listeners have to leave early before we finish this last question, I hope that you will please fill out the survey that pops up on your screen as you quit the webinar. So just take a minute to fill that out and get it back to us. I have a 19-year-old female, and she says that she's been diagnosed with TS, OCD, ADHD, and she feels that she may have autism. Is it possible that autism is actually the only disorder she does have?
I guess that goes back to the PDD Asperger's example that I gave a few questions ago. Are there people who it would take a lot of insight to say that you do have high functioning autism. Obviously, you have to be high functioning to know that you have it. But it is possible that, and I'll use PDD and autism interchangeably here, that patients with PDD have many symptoms like attention deficit disorder and even have tics. So it is, if you're asking if that's possible, the answer is yes.
Okay. If we have time for one more, okay, this is an interesting question. I have an adult who's taking meds for TS and for post-traumatic stress disorder, Klonopin and baclofen for the TS, baclofen, sorry, for TS, and Wellbutrin and Risperdal for the PSTD. The question is, are any of these redundant?
Baclofen and what was the other one for TS?
Let me go back.
Klonopin.
Klonopin. Klonopin and baclofen.
And what else?
And Wellbutrin.
Wellbutrin.
Wellbutrin and Risperdal.
Risperdal. Well, the Klonopin and baclofen are both somewhat sedating. Wellbutrin and so is Risperdal can be. There are different classes of drugs, but again, I'm a little bit concerned about the additive effects of all those medications. I hope one person is figuring this out, and it's not that one person gave one drug, another person gave another drug, because it certainly it's an unusual combination. Baclofen in and of itself is unusual for TS, but you know, it's mostly an anti-spasticity drug. I don't know, how it was prescribed, and as you mentioned earlier, many medications are kind of like a ladder. You build on one on the other, and I don't know how we got up to this.
But the key would be,
combination.
the key then would be that are they all being prescribed by the same doc, so that
I think that's an important question. And that doc needs to be aware of the, if you remember the last slide, of the interactions and cumulative side effects of medication.
All right, then I think we're going to wrap it up for tonight. Dr. Bennett, thank you very much. I'm going to turn the program over to Kelly. She'll take care of a few housekeeping things at the end. Thank you.
Thank you for joining our webinar on attention disorders and Tourette syndrome, a pharmacological approach. There is an exit survey which should show on your screen as you exit. Please fill out the evaluation on the exit survey. The discussion board will be open tomorrow and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted on the site. Our next presentation on hoarding will be presented by Dr. Jerome Bubrick and is scheduled for November 10th, 2010. This ends tonight's webinar. Thank you, Dr. Bennett, for your presentation, and thank you, everyone, for attending. Good night.